I'd like to start by sincerely thanking each one of you for coming today and giving IAMAI your time as we present the 17th edition of the India Digital Summit in partnership with Google and MessageBird. My name is Shelley and I will be your host for the day. We are happy to have you here and are looking forward to an engaging day of thought-provoking conversations and unmatched networking. To start with here today, let me give you a brief introduction about IAMAI. The Internet and Mobile Association of India is a non-profit industry body that represents the entire spectrum of the India's digital services. IAMAI has over 450 plus Indian and multinational firms as members of sector-specific committees such as digital transformation, digital advertising, logistics, edutech, fintech, gaming, and so on. The IDS today is a flagship event organized by IAMAI. With successfully organizing 16 editions over the years, we are proud to bring together the policy makers, path-making founders who will discuss and deliberate the India's digital growth story and the future of India across various sectors. The theme of today's IDS is Amrit Kal. As India celebrated 75 years of independence, the Honorable Prime Minister Shri Modi proclaimed that India has entered Amrit Kal. Amrit Kal is regarded as an auspicious time for beginning new endeavors, achieving prosperity, and reaping the rewards of one's workforce. India is also ushered in such an era on its path to becoming an economic powerhouse through the power of digital innovations, intelligent policy making, and entrepreneurial spirit. I would also like to thank our associate partners Google and MessageBird, growth partners Paytm Ads, our lanyard partner Kalera, our conversation media partner Bobble AI, our agenda partner Disney Plus Hotstar, our digital media partner Jagran New Media, and our silver partners CleverTap and AWS, our bronze partners Hexa Webony, Mool1, Exotel, Notify Visitors, PacePrint, True Balance. Coming to our today's session, this is a panel discussion on healthcare for all, delivering affordability and accessibility with new age models. Let me introduce to you our esteemed panel. We have Dr. K. Madan Gopal, Senior Consultant Health from NITI Aayog, Dr. Vaibhav Kapoor, Co-founder Pristyn Care, Mr. Archit, Garg, Co-founder Glamyo Health, Mr. Senu Sam, CEO and Co-founder Mykare Health, Dr. Tanushri Sidharth, Co-founder and CEO TaCa Healthcare. And to moderate this session, I would also like to call upon Dr. Purav Gandhi, the founder and CEO of Healthark Insights. And over to Dr. Purav Gandhi now.
Hello everyone, very good morning to all of you. Thank you everyone for joining, and special thanks to all the panelists for taking out time to discuss this very important topic around the new age business models in healthcare. I would like to start this discussion with a very important topic, which is where does India stand today from a healthcare perspective? We've been evolving very fast as a nation, and yet the challenges that we need to solve for as a country in healthcare are long. We are solving for scale, we are solving for quality, we are also solving for a country where the aspiration is growing very, very quickly. So maybe to start this discussion, my first question is to Dr. Madan Gopal. Sir, where does India stand today in terms of healthcare? What are the main challenges that we are looking to solve, especially the question of missing middle, which was highlighted in the NITI Aayog report. With regards to healthcare, what is the missing middle that India needs to solve today?
Thank you. First of all, I thank the organization for inviting me for this interesting discussions. So, as the question has been posed that where that India stands vis-a-vis the healthcare. If you have seen the journey of the country, we have first invested into the public sector. So till 90s, it was more or less a public sector driven health sector. As we opened up, the private sector also started expanding from the early 90s, and now we have seen a lot of private sector taking up. Having said this, if you look at the system which has evolved over the years, we have been talking about GDP spend on health. I'm not talking about the milestones and other things with respect to the indicators of communicable disease and other. I won't be touching on that because that's a separate kind of discussion. If you talk about the GDP spend on health, so we have been spending around in the range of 4 to 5% of GDP, including the private sector spending, and most of the spending happening from out-of-pocket expenses. That means if you take the latest National Health Accounts data, the out-of-pocket expenses is around 48%. That means whatever expenses are happening, if a person is spending 100 rupees, 48 rupees are coming from his pocket, not from the insurance, not from the government sector. And this 48 rupees is going for the diagnostics, medicines, your OPD care, and your laboratory investigation. Mainly it is focusing on that. But one of the challenges we have been talking about, we are signatory to universal health care. One of the indicators, benchmarks which have been set for universal health care is we have to reduce this out-of-pocket expenses to less than 25%. And many of the other countries are also struggling in this direction. That means plenty of road to cover, but the things are moving in the right direction. The last National Health Accounts, it talks about 71% expenses. That's why you have seen programs like generic medicines and to reduce the cost on the pocket of the people. We are moving in the direction. If you talk about the expenses in the private sector, around 70-75% health expenditure happens in the private sector. Mostly, as I mentioned, that 48% out-of-pocket expenses. But if you talk about the footfalls is more or less equal in the public and the private sector. And private sector is mostly catering to the secondary and the tertiary care, and whereas the primary and a bit of secondary and tertiary care is been rolled out from the government sector. One of the interesting things which has evolved over the years are different care models, because if you look at the way the out-of-pocket expenses happen, that means 1.4 billion, if you translate into just simple terms, 1.4 billion is chasing around 15 lakh doctors and purchasing their medicines or purchasing their health. So government sector is doing good work. You can walk into government sector, but there are certain other costs which are hidden, which the person usually incurs. But you have to see that how we aggregate this buying capacity of the people. That's why these new age care models and other things, they become very important. If you look at the population which is covered by insurance, it's around 5%. But if you look at the other population, the 50% population has been provided some assurance from the government in the form of PMJ program, Pradhan Mantri Jan Arogya Yojana. And some of the states have topped up and they have covered their population, around 11-12 states. They have extended the coverage of insurance to cover the rest of the population. That means in nutshell, around 70% of the population would be having some form of coverage either from the government sponsored insurance schemes or assurance schemes, or their own insurances. The central government services, the people, they would be having the CGHS, then the ECHS and the ESI scheme. So these are the various mechanisms, but a significant population remains. That means around 30% of the population needs to be having some kind of financial support. Otherwise, they land up spending money from their pocket and they fall back to the cycle of this catastrophic expenses. If you look at this 30%, they comprise around the middle, the upper two quintiles of if you look at the consumption pattern on health, the upper two quintiles are being taken care, either they are supported by government or they can buy their insurances. The lower quintiles are being supported by the various assurance, but these are the people. In this also, the lower quintiles, they are most vulnerable, because the moment some expenses happens, that is a catastrophe on them and they will come to that poverty level. So we are focusing on that, how to address that. Though we have released the report, we have addressed many things. We have been working with the insurance regulatory team. one vanilla product was there. But what is uptake? There are many distribution challenges, very challenge of volumes. And if you look at the scheme which has evolved, the health insurance scheme, health insurance is very challenging because the erstwhile RSBY scheme, it was health insurance. The allocation made from the government side was 750 rupees. But the insurance was quoting 130 rupees. How this kind of undercutting and other things can push the market to survive? They all say that we are burning cash and we are this. But when we have factored that it would be costing around 750 rupees per family and for a coverage of 30,000 at that time in 2008. And the people were willing to do with this. That's why we have to think about the procurement policy also, whether we have to go for the lowest quote or we have to ensure quality and other things. That's the different challenges. Looking at this, there are many models which have evolved. One is how to provide a consolidated care to the people. How to prevent the catastrophe, because now various products and other things have evolved in that direction because people have seen opportunity into that. We see that opportunities can lead to innovations. The bottom line is how these opportunities can reduce the catastrophe for that person. If we are able to work on that, then we are moving in that direction. I will stop here. We will take further questions after that.
Thank you, Dr. Madan Gopal, for at least setting the perfect tone for this discussion. My next question is to Dr. Vaibhav, and maybe for the benefit of everybody, right? If you can talk about like what are new age business models when we talk about this, and how are they trying to solve for some of these challenges or opportunities in whichever way we view them?
I think why have new age models come into existence, right? That is the first basic thing, right? Throughout my practice as well, when I was just practicing as a surgeon, I think there were three common things. There are three pillars to healthcare. One is the hospital, second is the patient, and third is the doctor themselves. So we have to actually dig deep. What all concerns do they have, right? Like sir said, India is a country where we have a dual dilemma. We say India needs more hospitals, but the truth also is almost 80% of the hospitals beyond the larger corporate chains, they work at a 20-30% utilization. So they are actually free. They need more patients, right? So it's a very large underutilized capacity, especially when you talk about mid-sized hospitals, nursing homes and all that. So they need more patients, right? Second, we say we need more doctors, but आप किसी भी doctor के पास चले जाओ, he wants more patients, right? When they want to set up their practice, कि मेरे पास patient आ जाए. So again, every doctor has additional capacity to see more patients, right? And of course, with patients, gone are the days where they would say कि okay, we want, बस surgery हो जाए. They say okay, we need a surgery, but we also need a lot of convenience because there are so many, different checkpoints, right from how do you identify a doctor, to your OPD, to your test, to your insurance, financial clearances, to your hospital stay, then discharge, then multiple follow-ups, and then probably, post follow-up physio or whatever. So there are so many checkpoints that currently that entire journey is very, very inconvenient, not just for the patient, but also for their attendants, right? Surgery itself is a fearful thing. साथ में इतनी सारी चीज़ें कम्बरसम और आ जाए तो it's really a trauma for almost a month and a half जब तक patient fully recover नहीं होता. So I think the basis of all new age healthcare companies is this, that these are the clear three problems and we have to solve for all these three problems, right? And the bottom line is, first, everybody is thinking asset light. We believe there are more doctors, there are more hospitals, so we don't have to build our own assets. So all the new age healthcare models believe that asset light is the way to go forward. Second, everybody is anal about the patient experience, right? Right from the beginning to the end, the patient experience has to be really, really high. And third, the base of everyone is technology. See, new age models are very heavy operationally, right? So although we talk that it is health tech, but the truth also is 90% is operations, right? It is heavy on the ground. Surgery to haath se hi karni hai, right? But coordinating all these 20-30 touch points has to be through technology. So we are probably think tech first just to create that seamless experience. So I think this was the basis of why healthcare or the new age models have emerged, and they work like a full stack healthcare service provider, right? That is why. And how we normally do it, and everyone does it, we have our own clinics, right? So these clinics are on the name of all these new healthcare models. They have the CE licenses or all the necessary equipments to run a clinic. Patients are seen by the doctors in the clinic. The surgery happens in the partner hospital, so we don't own the hospital, right? So they are full stack healthcare providers. That is the key thing in this. Yeah.
So maybe one question, and maybe you were going to touch upon that itself, but can you throw a little more light on this last part which Dr. Vaibhav mentioned? Are you aggregators? When you say you have your own clinics, like, can you talk a little bit more about the business model in general for everyone's benefit?
No, sure. I think very well, I think the context has been said by Dr. Madan Lal and Dr. Vaibhav. I think very interesting, very well. So let us first look at whether we use the word aggregator, new age. Let's put the terminology separately, because the terminology starts confusing people. So when we started the business, right, and I came from almost 10 years investing background in the healthcare industry, right? So when we started the problem from the hospitals, right, like Dr. Vaibhav mentioned. So we looked at hospitals, and we work with bigger hospitals, smaller hospitals, and in the smaller hospitals, the problem of utilization was quite grim, right? That they are hospital capacity, but they are not able to expand because the utilization is not there, right? Almost 30-40% utilization, and then it is vacant. But when you went deeper into the industry, when you started solving the hospital side, but you started looking at the patient side is actually which is even more challenging. And that is what we are trying to solve. What is the problem of the patient? There are three major or three terms I will use: lack of transparency, lack of affordability, and lack of convenience. What I mean by transparency, and I'm not saying there is a fault of any player particularly. So if I want to go for a surgery, which is the secondary care surgery, or it's a, let's say, hernia operation or a cosmetic surgery, what we have seen is that actually it is possible, based on the diagnosis, to define the price of the surgery before the admission. So you can actually come up with a fixed price surgery model. But in the hospital scenario, it is generally not possible to put a fixed price, right? So that was one big challenge, right? Can you actually define the price of the surgery before? Secondly, linked to that is, can you make it affordable? So today, as Dr. Madan mentioned, only 5% of the population is insured, right? And even if I look at, we get 30,000 inquiries every month. And out of the 30,000 patient inquiries, which are surgical inquiries, only 20% are having insurance, which means the rest 80% are going to pay out of their pocket. So they want something which is affordable. So they want to upgrade to a good hospital, a good doctor, but they also want something which is affordable for themselves. So not only fixing the price of the surgery, but making it affordable, cheaper than what other hospitals would quote in general. Transparency, affordability, and lastly, convenience, right? So convenience is, you go to the hospital, you have to wait for 1 hour, 2 hours for the admission, right? At the time of discharge, again, 2 to 3 hours of delay is there. So, and how are we solving that? So as an aggregator, or if you want to use the word aggregator, what we have done is we have assigned medical counselors. These medical counselors are relationship managers. So like you have a relationship manager if you go into a bank, you have a relationship manager who will help you throughout the journey. So he'll help you find based on your symptoms, diagnosis, he'll help you find the right doctor, right hospital. He'll design a package for you which is affordable and convenient for you, but also he'll help you in the journey in the hospital. So he'll make sure when you get to the hospital, your admission is done on time, you have, the room is available, the bed is available for you, your OT starts on time. Unfortunately, in many big hospitals, the OTs don't start in time. Discharge is delayed by 3 to 4 hours, right? And at the time of discharge, for a variety of reasons, the attendants have to spend time running behind the TPA desk, the billing desk. So that is something where we support the patients. So yeah, I think these are the three things we are solving for the patient. And I think the way we started is that, the problem looks small from the outside, but when you go deeper into, problem is very, very large. And you solve for 100 patients, 1,000 patients or 10,000 patients, right? There is an immense scope for us to solve this particular problem.
Thank you, Archit. So, continuing a little bit further on that patient theme, and next question is to Dr. Tanushri. Right? What I'm learning, during this discussion is, we're at this unique juncture where patients have an affordability challenge for sure, but at the same time there is also aspiration. They're looking for quality, certain degree of convenience. So maybe if you can share some insights on how is the patient behavior evolving in today's mind, is like quote unquote the popular word consumerism. Do you see that within surgical care?
Absolutely, because what everybody else spoke about is also the, why was the need for this new age surgical models to emerge. So one thing is that the consumer behavior, quote unquote consumer, but it is consumer because it's not always the patient who is searching for a good hospital. It's his attendants, his family, his friends. So it's a proper word to ask to say that it's a consumer who is actually looking at, and why is he looking at? There are quite popular names in the city, any city that he lives in, about the places which are trustworthy, have acquired the trust of the consumer already. But there is a scope because they are looking at affordability. So if you look at the evolvement of healthcare scenario, eye hospitals, then dialysis centers, and then birthing and IVF all used to exist within one in-house big hospital, which have come out and have already established themselves in a very robust manner to deliver quality healthcare. So if you look at everything else, approximately 30 million secondary care elective surgeries are happening in India in 1 year. And do we have a scope? Definitely, because the 10% population which is going to tertiary and quaternary care, private hospitals, is only 10%. So what about the rest? As we can appreciate, the government is bringing in a lot to address the masses. We still see that their government hospitals are struggling to provide, as just mentioned by Sir, that they're struggling to provide to the masses and complete or address the complete challenge that is there. So therefore, the new age surgical models do have a scope to come into the picture. The consumer has become smarter. They are going to the digital and electronic media to find out more. And it is our responsibility to give credible information to the average middle class consumer who is looking out for quality healthcare and who doesn't want to go to a quaternary and tertiary care healthcare where it will really burn a hole in his pocket. So that is the scope, and that is the opportunity we want to address, and that is the need of the moment, as we can see. So with the digital consumer behavior, we find that it is easier for us to address the scope because there are masses who are going to the digital media. And that's that gives us an opportunity to serve this population which is looking at secondary elective healthcare, which can be actually taken out of a tertiary quaternary healthcare and still deliver a good quality which the consumer is looking at.
Got it. Good way to look at it. You can maybe try to address some of the things at secondary level itself instead of moving them to tertiary, and that also resolves a capacity constraint. Also, one of the challenge I have seen patients faces, many of them might even if they have an insurance, don't know how to deal with the insurance process. It's fairly complex and overwhelming at times when you have your own relative who is in need of a surgery, in need of acute care. So maybe Senu, a question to you, like, are there processes and experiences that you create to help patients also solve for that? There is one thing having an insurance, the second is being able to avail it to the best extent possible.
So first of all, as Dr. Vaibhav, Dr. Madan and everyone have mentioned, why we started the company itself. So when I was in healthcare for almost 13 years and worked in almost the pan-India hospitals from Apollo to everywhere. And when my father undergone a surgery, I had to fly down to my native, and I was to take him to a small medium hospital nearby. And throughout the journey, right from connecting to that hospital, and my father was having insurance, and pillar to post, he has to run around. I think almost 3 days he was to wait for the pre-approvals, and the hospitals was thinking we are on the mercy of the insurance desk. So you just wait. Whenever the insurance is coming back, we'll get back to you. And even though he is having the full coverage, whatever is the desk saying, he has to just believe. Imagine look, I am from healthcare background, but even when he is calling me and saying, I am also not understanding why the coverage, even though the full coverage is there, why the pre-auth is not getting approved for everything. And the days gone, we admitted for the surgery. The entire process was completely, everyone has said, the fragmented journey. On the last day, the bill came, And even though the insurance was covering everything, we got a bill which extra we had to pay. And it was another surprise, like the nuances of the insurance, my father might not know. Remove me from that. The common man, which I was mentioning, the health care, I will put in the inverted comma, the care is missing for the missing middle of India. So I take my family itself into that. The care was missing there. And the bill came, and I have to see that, okay, where do I have to pay this? Because now it comes like a lot of inclusions, exclusions, and I don't have any power, or my parents don't have any power to go and fight with this insurance and to understand that, okay, this is not what you committed when you given me an insurance. So this is a typical example I am telling from myself. But when we are looking deeper into it, all our patients was also going through one or the other challenges like this in the initial days. I'll give one more example. When we started the company, the 10th or the 15th case when we are handling for a small medium hospital, and the insurance was rejected, and we started digging around, going behind the insurance company why it is got rejected. And with a lot of inquiries sent to the insurance company, they accepted that it is not a rejection, we are going to cover it. Where is the time for a common man to go and chase these insurance companies? So that's the moment we understood, look, it's not that I am going to help one patient. There are millions of patients like this who does not have the ability to go and dig around and get with the insurance. Now the hospital is coming back to me. Look, last 1 month, I have around 100 insurances rejected like this. Can you also help me to?
You are solving it.
Yeah, so it's coming, it's all connected. So that's the answer for this. Like we are here standing for that, fixing that care for the missing middle of India. And with insurance also, like we are going all out, because insurance penetration is increasing. At the same time, the literacy, giving more information and getting the best out of the insurance is required, and that is what we are helping the patients to do it.
Thank you for sharing that story. Very helpful. It makes it much more relatable, I guess, as opposed to being in theory. So I have a question for you. Moving beyond the patient, coming to the doctor element of it, right? They say overall medicine is complex and nuanced, and within that surgery is very nuanced. Like in some sense, almost no two surgeries are similar. At least there is something different between the same surgery, even if there are 5 appendectomies. Like how do we think of quality? How do we look for solving for quality in such a nuanced subject? And at a policy level, what is your thought on it?
I'm thankful that you have put this question, because we have been following the Western model. How the practice has gone there, we need to do the study. Where the certification happens and the board certified doctor, they usually claim. Do we have a board certified doctors here? We all look at the government for regulating our practice. If I have to regulate your practice, I am not a surgeon, I am a public health person. You are expecting me to set standards for you and regulate your practice. The problems which he has spoken, most of the insurance companies, they are engaged with the problem because the actuary who are there, or the underwriters who are there, are the medical doctors. If a cardiac surgery is to be done, they are a Unani person or a homeopathic doctor, he is approving the cardiac surgery to be done. So what that kind of mechanism, we have to build a lot of capacities into the insurance. Otherwise, one of the problems which we are still to crack that missing middle thing. We have developed that vanilla product of this IRDA, no takers, very less penetration. Why it is not there? Because the experience which he is facing, that's true across. If I don't have a jugaad in the hospital, I can't get the things done. And the young people who are not sick, they are healthy, they can pay for insurance, but after suing all this paraphernalia, it is better to pay, negotiate with the hospital, negotiate the price, it will be less than the insurance. The insurance will be 3 lakhs, and if I negotiate with the hospital, I need to pay only 1,50,000 or 1,20,000, and all the things done, no headaches, nothing. That kind of mindset is there because we have to crack this issue. We have been going to the people, talking to them, what will make you to come to this. Now coming back to the standards and the quality, when I was handling this RSPY for one of the states and at the central level also, at that time we had the quality initiatives. We have tried to evolve standards, clinical pathways, standard treatment guidelines for commonly occurring practice. It was just indicative so that it can guide the surgeons and the other person to follow. We had the guidelines for cholecystectomy, we had the guidelines for appendectomy, and the other common for the hernia operation. That is there. But who will regulate that thing? If you expect the government to regulate, then that means you will be prepared for that. Okay. So for the imaging services, you see the regulation and what the effects of that. How are we able to innovate in that direction? If you go to America, where the doctor, if you are having at least a blunt injury on your knees, he will immediately scan it then and there only with your mobile phone. Can that happen in India? Because the regulation is so strict that if you are having a scanning machine, you have to follow the PCP and NITI Act. Last time also when a few of the colleagues they came, I told that you regulate your practice, set your standards and ask the people to follow around. The moment you start having your own standards, own practice guidelines and you are following it, then obviously an endorsement can come. That would be an easier way to do this rather than asking. Ministry has created standard treatment guidelines for around 160, 170 process. 10 years down the line with the support of FICCI. It has not seen the day of the light. But if we can make, FOXG is creating standards for, they have given some guidelines for hysterectomies and the C-sections. And they are also struggling to see that all their members, they usually follow the guidelines which are there. The time has come that if surgeon associations are there, they should come up with their standards and ensure that at least their members, they follow it. If they start following it up, we can move in the direction of DRGs and the other thing which happens in US. Saying that the chamber they certify a doctor and they can take action against that. We have to move in that direction rather than the others regulating you, you regulate yourself. So you have to create standards, otherwise quality and other things would be struggling. So you have to see that how we create a solidarity kind of thing among all your practitioners. It's not that a big corporate hospital, you see, I feel very pity and very sad that in Delhi also now consultants, it is very difficult to become consultant now. Unless and until even in the corporate hospital, the HOD allows you to become consultant, you can't become consultant. The other kind of practice, which is a common notion, after 8 o'clock, 9 o'clock or 10 o'clock, you don't have any consultants even in the big hospitals. There's no doctor on call. How to ensure that? Because this has happened to one of our senior, very, very senior, minister rank person. One person was admitted in one of the big 4 hospitals in Delhi. And he has to be shifted to AIMS. Because there were no doctor. Consultant tha hi nahi raat ko. So that kind of standard, that kind of quality we are talking is not. You have to think all the 3 pillars which he has mentioned. Think from the patient point, provider point and the service point of view. And you create standards for them. And you self-regulate. As a broadcaster corporation, they have self-regulating them. Government is not regulating them. I think we have to think in that direction. This time has come that all professional bodies, they should come, they should make their own standards and ask their members to follow their standards so that a quality can be enforced. Even for the pricing also, or some pricing can be adjusted. आप ये बताइए आलू कहीं पे भी आप 10 पैसे का खरीद कर दिखा दीजिए 10 रुपए का खरीद कर दिखा दीजिए पूरे दिल्ली में except in the retail, except in the wholesale market. Otherwise जो 20 रुपए है तो कहीं भी जाएंगे 20 रुपए नहीं लगेगा. ठीक है? I'm not saying that this is I'm just setting an example how the associations and the professional bodies they work. If they set a rate, even for the hair cutting, barbers and solution, they have having a rate. They are having a union. They are having a rate. They set standards. ये करेंगे तो इतना होगा, ये करेंगे तो इतना होगा, इतना. Can't we come together and make standards for ourselves so that we can regulate ourselves? हम लोग ने बहुत सारे बनाए. We have done lot of work for creating standard treatment guidelines, clinical pathways बनाया, सब कुछ बनाया. But who will enforce them? It's very difficult. Even FOXG they are having guidelines, but they are also finding it difficult to enforce that guidelines in their 40,000 जो members जो हैं. So we have to see how how the professional bodies come forward and ensure this quality and standard. That's the only way out.
So that's a very powerful thought that you shared. Like if the government starts regulating, then the government will go in a certain direction. But it's better and probably in best interest of the industry and doctors to self-regulate and set their benchmarks. And I think you guys also, especially with the businesses you are running, not for all surgeons, you also are trying to build a scale. So are there such efforts that you are already driving? Is scale helping you solve for that in some way?
Yeah, maybe I'll take a first go, and I'm sure other panelists will add. So as a industry, the good thing is that, we have, from day one, we have followed, self-regulation, right? And all the new age players are working together closely in ensuring, in terms of quality, delivery at the hospital level, at the doctor level, that is controlled. So all the good things that sir mentioned, pricing, which level of doctors you work with, protocols for different kind of surgeries, what are the kind of qualifications that doctors should have, what are the quality, what are the parameters for the infrastructure that the hospital should have. So we as a group, all the people on the panel and all the new age healthcare models, so from day one we are following that as a self-regulating guideline, So doctors have to be, minimum 8 to 10 years experience post their specialization in the MS, right? Then there is a constant feedback which we get from patients. So after every surgery, we get a feedback from the patient on day 3rd, day 5th, day 30th, whether they are facing any infection, any complication, do they need to visit the surgeons again. So I think all these feedback mechanisms and, using a lot of, biases in terms of quality, I think helped us, self-regulate ourselves. And I think that is the focus, all the new age, at least healthcare players are looking at, because quality is utmost important. And what we are trying to do is empower the patients, who are earlier settling for a lower quality hospital or a lower quality doctor, trying to empower them and move them up to a better quality hospital and better quality doctor.
Got it. Dr. Vaibhav, the follow-on question to this that I have, has technology helped you in terms of doing this when you, because you run this across India, so many different locations, how do you leverage technology to help improve quality?
So, see, there are two ways to it. One is, when we talk about the surgical quality, right? See, अच्छी surgery is the basic hygiene. वो तो होनी ही है. So उसके लिए, like Archit said, quality surgeon is the basic necessity who has enough of experience to become a consultant in his own right. Even if he doesn't get opportunities in the corporate side, because of some sort of a hierarchy system, when he sets up his own practice, he has to be fully confident, years of experience, X number of surgeries under his belt to perform a surgery independently, right? Now a surgical outcome also depends upon a lot on how good is the operation theatre, how good is the instruments, how good was the treatment taken in the ward post-surgery, right? So I think the first part is the quality settings there. So like Pristyn, I think all new age models, so we have a team of quality consultants in-house, right? So when we onboard a hospital, there is a basic criteria to onboard, and then these consultants regularly go and train their staff, right? So when they go into an operation theatre, they'll probably take the OT nurse, the head nurse and the OT technicians and train them into the basic sign-in protocols, sign-out protocols, surgery khatam hone ke baad sari instrument count check karna hai, gauze piece count check karna hai, right? They'll see Boyle's apparatus theek chal raha hai, nahi chal raha. So all that medical part, right? I'll not go into too technical part, but the basic thing is if that part is done well, all the instruments are sterilized and everything, one check is already there, right? Second is, of course, in the ward, sometimes the patient has a fall, sometimes the patient has an allergic reaction, sometimes the patient has a blood transfusion reaction. So what to do? So we found a lot many times even the emergency kit in the ward was not ready. So these quality consultants will ensure that all these things are ready, right? So it not just helps the patients which are brought by us, but also the existing patients of the hospital, because the nursing staff is getting upgraded. So that is one. Now to do it in a distributed ecosystem across 40-50 cities, probably doing 500, 700, or maybe we together would be doing 1,000 plus surgeries every day, right? So to ensure that it happens in a distributed ecosystem, it cannot happen without technology, right? So for example, in our case, there is a hospital app, right, where they have to upload all these things regularly, right? There is a quality app where the nurse, whether a swab culture is taken or anything is taken, the nurse would upload it regularly, right? So there are multiple such parameters. So technology actually enables you to just ensure that there is regular update of everything. So for example, if today we are doing 600 surgeries, now all of us do electronic health records. Now when you are doing an electronic health record, every data to you is coming in, like that, and if you just put an OCR and put multiple parameters, so I know today if Pristyn is doing 600 surgeries, उसमें से कितनी surgeries में high risk patient है, किसका BP ज़्यादा है, किसकी sugar ज़्यादा है, किसको कोई blood thinner medicine पे तो नहीं है, किसी की age ज़्यादा है, so all that is automatically mapped. So technology helps you to enable that कि probably 10,000 kilometers away from here, you actually know that okay, this is a patient which is slightly high risk, and you have to ensure that a hospital which has been chosen for the hospital has full cardiac backup. So technology enables you to do all these things. Yeah.
Thanks for sharing that, Dr. Vaibhav. So what you guys are doing, right, fairly complex. We're learning that as we move on the discussion, and the magnitude at which this needs to be done is also huge. Now, when you're doing something that large, obviously there are challenges, and maybe would like for all of you to also share a little bit about what are some of the challenges that you are facing as you are trying to build these business models.
I think the only thing which keeps us awake in the night is how do we ensure that there are multiple enough barriers in place that prevents any high risk patient from going into the OT, right? And that to do it in a manner that it is still seamless. Patient doesn't feel कि यार ये multiple blocks लग गए. So I think every work which we do is in context to that, because from here, you today are doing 500, 700 surgeries a day. Tomorrow you will do 1,500 surgeries a day. Any surgery gone wrong, all good work is zero. So I think that is the basic thing, right? And for that, the only method is technology, right? So today, when a doctor uses his app, he can see all his patients, what all OPDs he has, what all follow-ups he has, what all patients, surgeries he had done last night, right? How are the vitals of the patients in last night, because hospital puts those vitals in their app and everything. So one thing is key to scaling is that how do you ensure safety and high quality at all times. Second thing is how do you ensure that the convenience part is still maintained, right? I think everybody gave examples of conveniences. So for example, we do work with a lot of larger hospitals as well, because not all the hospitals, even in the large corporate sector, have a 80-70% occupancy. They still occupy at 50%. So like he mentioned, normally admission time takes 1 hour. Patient hospital में पहुंच गया, admission desk पे उसके आगे 3-4 patients हैं, तो 1 घंटा तो सिर्फ admit होने में लग जाता है. So what we've done is, now you traveled yesterday, you would have taken a flight, suppose आपने एक दिन पहले prior check-in कर लिया होगा, right? आपने पहले ही boarding pass निकाल लिया होगा, so that अगले दिन आप सुबह line में ना लगो. Similarly, what we try to do is we take all the patient documents a day prior. We send all these patient documents on a hospital app to the hospital. Hospital understands that okay, I have received every document of this patient, and hospital will generate a ticket. So this ticket goes to the patient. So next day, patient when he comes to the hospital, even if there are 3-4 patients in the line, patient directly goes to the counter and shows that ticket. Now that ticket means अच्छा इस patient के मेरे पास सारे documents already आए हुए हैं. So this patient doesn't have to wait. So he just has to sign. They will take out the printout of all those documents. He just signs and he goes to the room. So a simple thing कि अच्छा मेरा wait time 1 घंटे से 10 मिनट का हो गया. So these are small things which you do, which actually help you, and these cannot be done with so we don't have any people on the ground, right, in the hospital. So everything is technology, because at scale you can't add a lot of these peoples. So that is the main thing.
As I mentioned, I started my career with Apollo Hospital. So I heard a lot from Dr. P.C. Reddy also, like when he started in 1980s, it was only public hospital was available. The first X-ray machine to get into his hospital, the challenges which he has gone to, even to have a law in the parliament to allow him to. So that was a new model that time. So you can tell that was a new age hospital model has come that time. So years later now, this is a new age which we are building it. So the acceptance in the industry, like we are trying everything to make sure the best to the patients, apart from what Vaibhav has told, for the hospital and the doctor. But the acceptance still is, I feel it is little far that, okay, these are new age companies. Yeah, that is one. And second, on the government side, if the tax, giving some more tax consideration for the new age. If you are as a hospital, if you are as a clinical establishment, there are a lot of taxes there. So I'm not pointing out much, but I'm just telling one or two.
Smiling already at the suggestion.
So, yeah. So this, apart from the customer experience, I just want to add these 2 points that
sure.
the acceptance from the industries and the bodies, and it's coming when the patients itself is getting the testimonies more that these guys are there for something good for them. So, but these 2 are the things from my side.
So we all have worked in hospitals for more than 2 decades. So we do understand the pain points of the patients, and we do understand what are the landmarks and what are the milestones that we need to create. But you know, one thing is very difficult, that is the surgical workflow. Because when our surgeon goes into an OT, and there are such micro processes which he needs, which creates familiarity. So initially, that is a very big problem, because the surgeon and the rest of the team there are to create a seamless surgical workflow. Actually, it needs a lot of effort and a lot of effort on our side to get that stitched together. After that, of course, when it is post-discharge, the patient is again in a facility in a ward where the familiarity for our team is a little low as compared to the familiarity of the native team there. So that again, it takes a lot of effort. As you said, how did it make it difficult? So that understanding and the seamless workflow, we have to really go double the effort to make that very comfortable for the patient. So I think that's one of the more technical, the more clinical part of it, to have a seamless workflow. I think that is very important, and that's a really difficult task.
Fair enough. Okay.
I'll keep it very brief. So I think, so first I think what is required, right, or the challenges that you mentioned, I think all the stakeholders have to realize, what benefit we are bringing for the patients. All the new age models, we are asset light, and I know different parts of different stakeholders have different viewpoints, about being asset light. But I think the way to look at is how we are helping the patient. We are bringing better convenience, as we spoke about it. We are reducing prices, not only for the patient, but a lot of time for the TPAs also, right? Bringing better utilization at the hospital level, better utilization at the doctor level. So, multi-level support is required. We need support from the government agencies, in terms of regulations which are friendly to new age models. They should look at the good work. Glass is always half full, half empty, but they should look at all the good work that we are trying to do, right, for the patient, and bring in regulations which are friendly, which includes better clarity on the GST. There were NMC guidelines, which a lot of times we were not sure whether they are helping the new age models or working somewhere against the new age models. So I think always would request sir and wherever he is representing the government, to take us as part of the industry and help us do the good work. Same goes for the doctor bodies as well as the TPAs, right? Our interest is aligned with them, bringing the pricing down. With doctors, we are trying to work along with them. With the hospitals, again, we are trying to work along with them. So I think multi-level support is required, and I think as we have more conversations like this will help us, send that message across to the industry at large.
Well, thank you for sharing that. Just in interest of time, I would like to ask one last question to sir. So you heard there are a lot of things that companies are looking from the government in terms of support. But what is the government looking for new age models, for private players to come and solve for the country? What should these companies be thinking about?
In my initial remarks, I think I have given this answer. That means we are trying to bring down the out-of-pocket expenses to less than 25%. That's a challenge. How to do that? The government alone is trying to do that, but the efforts of the private sector is also required. How to bring down the prices? Because it's very pity that 48% people, they are buying their health care, negotiating with around 15 lakh doctors or institutions. Such a fragmented thing. Some efforts which the new age care models are coming, but if it's not done in an organized way, this will also meet the same fate as the other businesses are coming. One or two will be surviving and the others would have to diversify. We have seen that how it survives. But in the interest of the patient, reducing cost, that means at low cost, how a good, affordable, quality service is made accessible, and they are trying to make an attempt in that direction. We see that how it progresses. And lot of work is to be done. They are only working with the small insurance sector only. Very few paying patients. And insurance penetration is not that high. The missing middle population is left out. We have to see that how we bring confidence in the missing middle. That's the only thing. The distribution challenges, the accessibility challenges, the availability challenges can be addressed. But the confidence of the population, how to bring that confidence. The example he has cited is just a tip of iceberg. Even I am well connected, but once it comes to negotiating with the insurance or other things, it becomes very difficult. For negotiating for the services aspect. I have worked with most of the insurance companies, but once it comes to the TPN, the lower rung of the administrators, it's very, very, very difficult to get them on board because they are there having their own ideas. So that's a challenge, and we see that the only request is that how you set your standards, how you make the things accessible, make the things affordable for the poor people, so that our vision of reducing out-of-pocket expenses happen. This PMJ and other kind of programs are aimed at reducing out-of-pocket expenses. And if the private sector also joins in, at least that catastrophe which the person faces, that is reduced. We have to focus on that. We have to uplift the people, not bring the people because of this catastrophic expenses to impoverishment. We have not to add to the misery, but to uplift them. So we have to aspire to uplift them so that this out-of-pocket expenses also comes down. So that's our whole of the vision, and I think with the younger team, I was just discussing with him that I am the only senior person here, rest are all young, new age people. So that's the only thing. Okay, thank you for this.
All right, thank you, sir, for that answer, and thank you for the overall participation. I would like to thank all the panelists for sparing their time and sharing their wonderful ideas on this emerging topic, which is very important to the industry, to the country, to all of us as population, as consumers of healthcare eventually at some point in time. So thank you for your time.